Hello everyone, good afternoon. Great to see so many of you and thank you very much for tuning into our webinar. Today we're going to be discussing the use of the cytokine GM-CSF as a culture and a transfer media to improve outcomes for advanced maternal age, miscarriage and repeated implantation failure patients, and to improve implantation rates in frozen embryos. We're just letting in delegates and we'll start this webinar very shortly. And a warm welcome to today's webinar, Embryo to Endometrium, How GM-CSF Can Help. I'm Emily Austin. I'm the General Manager of CooperSurgical's Fertility Solutions business in the UK, Ireland, Germany and the Alpine region. And it gives me great pleasure to welcome you to our webinar today. We've been very much looking forward to this webinar. A large number of you have signed up. Thank you very much. This has proven to be a topic that's resonating with those of us working in the field of fertility. And discussing this today, we've got a great panel for you, including an international guest with Dr. Stephen Fleming. Steve is an Honorary Associate at the University of Sydney and Director of Embryology for CooperSurgical. Previously, he was the founding Scientific Director of Assisted Conception Australia and a Senior Fellow at the University of Queensland. After completing his doctorate in 1987, he undertook postdoctoral research at the Royal North Shore Hospital in Sydney. And from 1993 to 1997, he was appointed lecturer in obstetrics and gynecology at the University of Nottingham in England, where he established the world's first master's degree in assisted reproduction technology with Simon Fischel. From 1998 to 2008, Steve was the Scientific Director of Westmead Fertility Centre in Sydney and appointed Senior Lecturer in Obstetrics and Gynecology at the University of Sydney. He is the recipient of numerous research grants and an author and editor of several books, book chapters, and peer-reviewed journal articles. Steve's research interests include cryopreservation, endometrial physiology, endometriosis, and oocyte maturation, amongst others. Steve, it's great we've nabbed you whilst you're on our side of the planet over here for the ESHRE conference, and it's lovely to be talking to you, not at some strange hour, as it usually is for at least one of us, but during the day for both of us. Steve is going to take us through the research and the clinical documentation to support the use of GM-CSF. We also have Stacy Macpherson with us today. Stacy is the Clinical Application Scientist for the UK and Ireland at CooperSurgical Fertility Solutions. Stacy graduated from the University of Sheffield in 2009 and has worked in reproductive science ever since. She has 14 years' experience in the field of embryology. Stacy trained in the NHS, where she completed the ACE certificate and attained HCPC registration as a clinical scientist. In 2015, Stacy moved to a private fertility clinic in London, where she progressed from clinical embryologist to deputy laboratory manager. Stacy served on the professional body for clinical embryologists, the ACE committee, from 2015 to 2018 as ACE webmaster. In her role as clinical application scientist, Stacy enjoys education and training, particularly in trophectodome biopsy and vitrification. Today, Stacy is going to be outlining how GM-CSF works. It's an interesting molecule with numerous mechanisms. And we're really pleased today to have Dr. Catherine Pretty joining us. Catherine has a long-standing interest in reproductive science since her PhD at the University of Nottingham under the supervision of our very own Dr. Steve Fleming. In her PhD, Catherine studied changes in the endometrium during the process of decidualization and in early pregnancy. Since then, Catherine has had a 25-year career as a clinical embryologist working in Australia and around the UK. She now works as laboratory manager at CARE Fertility in Woking. Catherine has a particular interest in the management of patients with repeated implantation failure, miscarriage, unexplained fertility, and patients of advanced maternal age, and is pleased to talk to us today about her day-to-day experience of using GM-CSF enriched media for these patients. It's really great when we get speakers joining us who share their experiences, and this is very much an experience that Catherine is going to share and not a formal study. So we will look forward to Catherine sharing Woking's real-life experience of using GM-CSF. It's also great to reunite Catherine and Steve. It's lovely to see them together in this webinar today. Just before I hand over to Stacy, as a reminder, please enter your questions into the chat box. We'll go through as many questions as we possibly can. I'll put as many as I can to the panel after the discussion. As always with our webinars, we're here to provide you with information and answer your questions, and no question is too small or too big, so please ask away. Stacy, I'll hand over to you.
Thanks, Emily. Just trying to get my slides to move along. There we go. Okay, great. Hi, everybody. So my job today is to talk to you about our Sage One-Step GM-CSF media. I'll start by introducing the product and then by explaining some of the science behind GM-CSF. I'll then hand over to Dr. Steve Fleming, who will talk you through clinical documentation supporting the use of GM-CSF in embryo culture media. Sage One-Step GM-CSF is a single-step culture and transfer medium containing the cytokine GM-CSF. GM-CSF supports embryo to endometrial communication. It's been shown to improve embryo development, implantation, and chances of pregnancy. It provides an additional treatment option for patients with a previous failed treatment cycle. With this in mind, we'd like you to think about what your current patient population looks like. What's the average age of your patients? How do you treat patients that have undergone failed cycles due to implantation failure or miscarriage? Do patients come to your clinic because they've had failed treatment elsewhere? Sage One-Step GM-CSF may provide a new treatment option for patients in need. GM-CSF containing media have been shown to be particularly impactful for patients that have undergone more than one miscarriage, implantation failure, and for patients of advanced maternal age. A recent study also showed a benefit of using Sage One-Step GM-CSF for frozen embryo transfer cycles. I won't give too much away right now, but there's some really exciting data from this study that Steve will share with you shortly. Sage One-Step GM-CSF is a culture media, and because it's a culture media, it can be seamlessly integrated into your laboratory workflow. It can be used for fresh culture and transfer cycles. You would use it in the same way as Sage One-Step or most other commercially available media. It can also be used for frozen embryo transfer cycles for post-warming culture and transfer. Sage One-Step GM-CSF is built on our trusted Sage One-Step medium. Sage One-Step has been available since 2015, and it's now used successfully by clinics all over the world. Those of you that already use Sage One-Step will know that it contains hyaluronan. The novel combination of GM-CSF and hyaluronan makes Sage One-Step GM-CSF an innovative option for culture and transfer. The product contains 2 nanograms per milliliter of recombinant human GM-CSF. It's pre-supplemented with 5 milligrams per milliliter of HSA. The pH range is 7.2 to 7.4. The product has a long shelf life, being 26 weeks from the date of manufacturing, with a 7-day open bottle shelf life to prevent wastage. Now, back to the science. What is GM-CSF? Well, it's a bit of a mouthful. It stands for granulocyte macrophage colony stimulating factor. GM-CSF is a cytokine. Cytokines are small secreted proteins released by cells that have a specific effect on the interactions and communications between cells. Put simply, for today's context, GM-CSF is a natural signaling molecule that allows for communication between the embryo and the endometrium. How does it work? Well, GM-CSF is present during natural conception. It's secreted into the fallopian tube and into the uterus, and we know that it's elevated around the time of conception and implantation. GM-CSF works via receptors expressed on the surface of the embryo from the zygote through to the implanting blastocyst stage. It regulates synchronous development to improve the chance of implantation success. We know that the communication continues after implantation, as trophoblast cells also express GM-CSF receptors. But what does GM-CSF do? Well, GM-CSF is a multifunctional cytokine. GM-CSF is secreted into the fallopian tube, helping to ensure immunological response. Remember, the developing embryo contains paternal antigens. In vivo, the uterus may recognize it as a foreign object and in some cases reject it. GM-CSF helps to facilitate a communication pathway to allow the uterus to respond to the presence of the embryo. GM-CSF supports cell survival. It's a survival factor. It helps to prevent the apoptosis of cells and to protect the embryo from cell stress. The presence of GM-CSF promotes chances of implantation and also reinforces ongoing pregnancy. A study published in 2003 measured GM-CSF serum concentration in women with sustained pregnancy versus women that had suffered from recurrent miscarriage. You can see from the graph here that in women with sustained pregnancy, the GM-CSF concentration continues to increase throughout the first and second trimester of pregnancy. However, in women with recurrent miscarriage, the GM-CSF level barely gets off the floor. This study tells us that not all women are capable of producing sufficient levels of GM-CSF. We also know that the embryo cannot synthesize GM-CSF. Therefore, there is sense in including it in the culture media itself. All we're trying to do is mimic something natural, which is what we've been trying to do since the birth of IVF itself. We're trying to mimic something natural in an unnatural environment. Now, let's look at some of the clinical documentation of GM-CSF in culture media. The use of GM-CSF in culture media is supported by 25 years of clinical research. These studies have shown the presence of GM-CSF in culture media can enhance blastocyst yield, support embryo survival, and increase clinical pregnancy and live birth rates. GM-CSF may protect embryos from culture-induced stress, and it may rectify embryological and reproductive outcomes. A recent study also showed that stage 1-step GM-CSF improves live birth rates in FET cycles. It's now time to hand over to Dr. Steve Fleming, who will discuss the clinical documentation in more detail. Over to you, Steve.
Thank you, Stacy. I'll try and share my screen. There we go. So thanks for that very nice overview, Stacy, and thanks also, Emily, for such a nice introduction to us all. It's really a great pleasure to be talking alongside Stacy and Catherine. So my job really is to give you a bit of a short potted history, if you like, from the very early preclinical studies all the way through to some of the very recent clinical studies actually using stage 1-step GM-CSF. So where did it all begin? Essentially, Professor Sarah Robertson went over to Mats Wiklund's lab in Göteborg in Sweden and did some studies with Cecilia Sjöblom there. And essentially, these studies set a proof of concept, if you like. So this was early proof of concept study of media, and they looked at various types of media. And these media contained, in all cases, 2 nanograms per mil of human recombinant GM-CSF, which, of course, is what we use in the commercially produced media now. So this was conducted all the way back in 1999 on frozen human 2 to 4 cell embryos that have been donated for research. And they're particularly lucky in Sweden that there was an ample supply of this kind of research material, essentially based upon the fact that you could only store human embryos for so long at that time in Sweden. And so they sort of went into these studies and weren't sure what they were going to see. But they were absolutely amazed that when they came to look at the embryos, for example, at the blastocyst stage, that GM-CSF in the media had increased the blastocyst formation rate from around 30%, which in those days was pretty good going for blastocyst formation, up to 76%. They couldn't really believe what they were seeing. It also increased the rate of expanded and hatching blastocysts. And significantly, only those blastocysts that were cultured with GM-CSF were able to undergo trophectoderm outgrowth onto the culture dish. And trophectoderm outgrowth is widely accepted as the in vitro correlate of implantation. So this was really, a seminal study that I think paved the way for all the studies that have since occurred. So fast forward to 2013, and this study was published, and it was the first clinical trial of culture media containing GM-CSF. And essentially, at that time, the culture media that was being produced by Embryo for standard culture was Embryo Assist. So the control group were Embryo Assist, and the experimental group was Embryo Assist medium, supplemented again with 2 nanograms per mil of GM-CSF. And this was a multi-center randomized clinical trial of 1,332 patients from 14 Scandinavian IVF centers. And this first randomized clinical trial found that GM-CSF was particularly efficacious with respect to ongoing implantation and live birth rates in women who had experienced a previous miscarriage. And you can see that in this subgroup analysis of 289 embryo transfer cycles. And so you can see, 7, 12 weeks and live birth, these significantly higher rates when these embryos had been cultured in the presence of GM-CSF. And furthermore, in terms of the safety of the media, if you like, there was no significant difference in birth weight and neonatal morbidity or mortality. And indeed, the gestational lengths were, again, just the same as they were in the control group. So that was particularly reassuring moving forwards. And in fact, leading to the subsequent development of culture media containing GM-CSF. And now, importantly, in terms of understanding what GM-CSF is doing, this follow-up mechanistic analysis of that multi-center randomized controlled trial revealed that GM-CSF seems to protect morphologically normal embryos, presumably from the stress of being cultured in vitro, but there was no evidence for a similar role in rescuing poor quality embryos. So you can see from these histograms on the right, these are the what were designated the top quality embryos. You can see that GM-CSF has, clearly enhanced the live birth rate of those embryos compared to the controls. Whereas if we look at the so-called abnormal embryos, well, these may not have been abnormal embryos. They were just not such good quality embryos, poor quality embryos. You can see that GM-CSF in those histograms is not having a similar impact on these poorer quality embryos. So the authors concluded that the use of GM-CSF containing medium increased the live birth rate predominantly because of the improved implantation potential of the good quality blastocysts. Now, once media had been manufactured commercially, this was a year later after that first randomized clinical trial. This was a subsequent retrospective study of 197 women that had suffered previous failed IVF or ICSI cycles. And although this study showed that there was no significant difference in the clinical pregnancy rate, albeit higher in embryos that were transferred following culture in Embryogene, which is the cleavage stage medium containing GM-CSF, there was nevertheless a significantly higher ongoing implantation rate at 7 and 12 weeks of pregnancy, which actually isn't in this figure. But there was also a lower frequency of first trimester pregnancy losses, which you can see here in the histogram on the right. Again, it would appear that GM-CSF was supporting not just the implantation of these embryos, but the sustained pregnancy and hopefully avoiding a miscarriage from occurring. Now, this is a really interesting study. I mean, you look at those histograms and you think, oh, there's not much difference between those, looking at the GM-CSF and the control media groups. But this was a retrospective case-controlled study that identified, so they managed to actually look at 49 patients they originally identified over a period of time that had undergone cleavage arrest during a normal cycle of IVF. Following their inclusion and exclusion criteria, this was whittled down to 39 patients. And these patients, as I said, had a history of developmental arrest of their embryos in standard culture media. And they defined embryonic arrest as being a failure to reach embryo transfer following 2 consecutive cycles, where at least 6 oocytes had been retrieved and at least 5 of them had fertilized. So in a subsequent cycle with these poor prognosis patients, they matched them with a control group that had tubal factors, so good prognosis patients, and they matched them from their database in a 2-to-1 ratio, so good design in terms of control of the study. And those embryos were cultured in sage 1-step medium from Embryo. And the embryos from the previous embryonic arrest group were cultured in Embryo. And as you can see in these histograms, Embryo effectively resulted in apparent rescue of these patients that had had such a poor prognosis previously. So when you look at these histograms, there's actually no significant difference in clinical outcomes between these 2 groups. Now, you could say that, you know, this might have happened by chance, but I think when we're looking at 39 patients that had previously had cleavage arrest in their previous 2 cycles, it would have been surprising if all of them had suddenly had a normal outcome. So again, this suggests that GM-CSF may have some kind of supportive role in these patients that had previously suffered arrest of their embryos under normal in vitro culture conditions. And so bringing us up to date, this is a recent study which analysed the clinical outcomes of blastocysts that were cultured in NACA 1-step medium. Now, just to sort of put this into perspective, NACA 1-step medium is kind of a very similar media to sage 1-step medium, let's put it that way. So these were cultured in NACA 1-step medium and were then vitrified. And then over a period of time, these vitrified blastocysts were then warmed and they had recovery culture in either, again, the NACA 1-step medium or sage 1-step GM-CSF medium. And the recovery culture was for 3 to 5 hours post-warming and prior to frozen blastocyst transfer. And as you can see in these histograms, the rates of clinical pregnancy, ongoing pregnancy, and live birth were all significantly higher in the GM-CSF group. Though interestingly, there was no significant difference in the incidence of pregnancy loss. So what can we summarize from all of this? Well, as Stacy, I think, quite clearly explained, this is a cytokine, and the role of cytokines is that of signaling. And there's now plenty of evidence that GM-CSF mediates embryo endometrial communication. It facilitates successful embryo development. And I think probably the most important thing that it does when we think of things like in vitro culture, especially extended culture, cryopreservation, whether that be with slow freezing or vitrification, these are all stressful events for the embryo, and the evidence so far seems to suggest that GM-CSF protects the embryo from cell stress. It also appears to promote the chance of implantation, and through immunological work that's been done by reproductive immunologists such as Sarah Robertson, again, there's very good evidence that it moderates the immunological response to implantation and allows implantation of the fetal allograft. And so in these ways, it combines to reinforce ongoing pregnancy. So it's possible that it may be, a worthwhile treatment option for both culture of embryos and transfer of embryos. My suspicion is that it's going to be particularly beneficial in situations where embryos have been subjected to cumulative stress. So let's say the stress of in vitro culture, well, maybe the stress of micromanipulation, that's conducted outside of the incubator in an atmosphere of 21% oxygen, and then the stress of in vitro culture over an extended period of time, and then the stress of vitrification and warming. So these are all cumulative stresses, and that's where I suspect that GM-CSF is likely to be beneficial. So what are the sort of patients that may also need additional solutions? Well, patients that have experienced miscarriage, those that have experienced implantation failure, and those where their gametes and therefore their embryos may be a bit more vulnerable. So couples of advanced age and particularly with advanced maternal age. So I'm going to stop there and with absolute great pleasure hand over to Dr. Catherine Pretty. So I shall try and stop sharing. I can.
Thanks, Steve.
Oh, you've done it for me. Thank you. Yes, I'm still analog old school, I'm afraid. But anyway, it's great to hand over to Catherine. It's all yours, Catherine.
Thanks, Steve, and thank you, Stacey. Lovely to be here today. Thank you to Emily and the team at Cooper for inviting me to talk. Really interesting to hear all those, amazing projects and research topics we've had there. I'm going to talk from the other side of things, from the sort of lab day-to-day side of things. So hopefully the two talks will combine nicely to give you a picture of how this might work in the IVF lab. So my name is obviously Catherine Pretty, and I'm the lab manager at CARE Fertility in Woking. My talk today is covering some numbers from both when we were CARE Fertility and also when we were with the same team in the same town, but as another clinic called Nuffield Health. So this data isn't all from the CARE Fertility database, but it's my own personal experience over about 10 years of using Embryo. So I thought I'd talk about I was going to cover what GM-CSF is, but that's been covered so well by our previous speakers. I'm going to leave that with them, but talk about how we could use it, what patients we recommended it for, how we actually manage the use in the lab every day, and what our results were just in the real world. First of all, I wanted to include this jigsaw, which I quite like using when we spoke to patients about GM-CSF and how it can help. Talking about how a successful outcome isn't one thing and one thing alone. You need all the parts of the jigsaw present in order for it to work. So you need to have, the embryo has to have chromosomes that are competent to form a pregnancy. You have to have a good, successful embryo transfer technique into a receptive endometrium. And it's only when those things are in place that really the GM-CSF factor is going to be helpful. Obviously, there are times when these things may not be black and white. We could have a scenario where things might not be optimal, but could be rescuable. So there is that scenario. But really, we wanted to say to patients that GM-CSF wasn't something we recommended to every single patient in every single scenario. So our patient group that we used to use the GM-CSF media, and we used Embryo media for this, is actually pretty much what was supported by the research papers shown by Stacy and Steve, which I'm delighted to see. We offered it to patients who had recurrent previous failed cycles. Perhaps they had either a negative pregnancy test or a miscarriage, or biochemical pregnancy, or the unexpected implantation failure. We really offered it to them for the people who had no obvious cause for that. So people who had good blastocyst development, but that it led to the unexpected outcomes. We used it as a sequential culture system. So we used Embryo from days 1 to 3, and then we used the BlastGen media from days 3 to 5 or 6, and for the transfer. These days, of course, they've got the new single-step culture system, stage 1-step GM-CSF, which I am excited to be looking into, but that's not something I have experience of using personally yet. It's relatively new to the UK. So we started using it in 2014, which is about when the paper started really coming in on its success. And we started using it originally for days 1 to 3. And then if someone was having extended culture, we would do that extended culture using standard culture medium, and then do a short period of culture immediately prior to transfer and the actual transfer procedure using the Embryo media. But quite soon after that, another year or so, BlastGen itself was brought out by Cooper, and then we started using that from day 3 onwards, and then for the transfer as well. That was then optimised for the 2 different stages of embryo development. As I said, we're now looking into the possible introduction of the 1-step GM-CSF, but that's looking to the future. So as I say, we looked at this for people who needed implantation support. We generally aimed it at patients who'd had at least 2 good quality blastocysts replaced in previous cycles that were negative. We generally aimed it at people who are less than 40 years old. That was always on a case-by-case basis, but the general idea was that over 40, genetics was more likely to be a factor than implantation failure itself. Really interesting hearing some of the talks that Steve and Stacey just presented, and this is something we might well look at revisiting. We only used it in frozen cycles if it had been used in the preceding fresh cycle. So if the embryos had been cultured in that from the early days. Again, that latest paper really draws that into question as to whether you could use it for the first time in a frozen cycle. Certainly patients were interested in doing that, particularly after maybe a couple of failed FETs. That's something that would be really interesting to look into. That was how we started using it. Later on, we did start including older patients simply because our experience with it was that it was working well in that age group. So it became more and more difficult to turn away a patient at maybe 42, 43 years old, when we actually found that when we were doing it on occasion, it was working quite well. So as time went on, over the 10-year period we were using it, we did have an increase in older patients that were using it, and with some success. So that was something we did move forward to do. One thing I was really pleased to be able to offer it for was patients who came to us without having had fertility treatment, but with a history of natural miscarriage. Now, apart from genetic testing, which is an obvious pathway to follow for these patients, if they're getting implantation failure with euploid embryos, there's really not a lot that we can necessarily offer in the IVF clinic. People are often getting pregnant quite easily. It's the keeping pregnant is the issue. So to be able to offer something to these patients that would actually be helping them was something positive emotionally for them, and seemed to have some good results, though the numbers were relatively low for us to give any definite answers on that. And as I said, we'd like to think about using it in frozen cycles, regardless of whether it was used in the fresh cycle where the embryos were created. So how we introduced it to patients, it was a chargeable additional treatment. We didn't use it as our standard culture system. It was something that patients could opt into and pay for. It was generally discussed with the patients during their clinician's review. Most of these patients had already had a failed treatment cycle, so they were coming back to see the doctor to talk through that. We had a system of 360 reviews where the patient's notes would be analysed by the lab team, the nurses and the doctors before the review. So often the lab team would be the ones who were quite keen on it. We really liked using Embryogen and enjoyed using it for some of these patients and liked the results. So we would quite often put it to the doctors as a possibility. So it often came from our side of things. It's important, obviously it came with written patient information. The patients need to know what it is they're opting in for, what it can help with, what it might not help with, and be aware that the fact it is an additional charge. So it was always had with a discussion, always people had a chance to understand the pros and cons of using it. Consent, sometimes these additional treatments have written consent. That really is a clinic by clinic decision. As to whether you have signed consent for it or whether you treat it as the patient's given the information and given the okay. So some practical considerations on how we used it day to day. We did treat it as an opt-in system, so it wasn't automatic for anybody. We wanted it to be confirmed at least the day before egg collection in order to allow the dishes to be pre-equilibrated. As you can imagine, that doesn't always work as smoothly as you'd like, but generally patients were happy with whether they were using it or not well in advance of their treatment cycle. We then made up that Embryogen dish and we used it from day 0 or day 1 up until day 3. We basically used it whenever you would put the embryos into culture. So if you'd done your ICSI procedure, we would move the embryo straight into Embryogen, or at IVF, it would be done at the point of the IVF fertilization check, just the same as we would for a normal case. And then on day 2, we'd make the BlastGen dish ready for use on day 3, and we'd move the embryos across, usually in the morning of day 3. The transfer would take place at whichever medium was appropriate. BlastGen was general because we usually cultured to day 5. As anything, it's there's always hiccups and day-to-day realities of working with anything. So really, the biggest challenge we had with Embryogen was tracking any treatment someone has that's different to the norm. You've got to make sure that everyone's aware, it's well communicated, people are on top of what's that. So that was our biggest challenge, but our team worked really closely together and we didn't really find it a big issue. For us, at the time we were using it, our standard culture was actually in stage 1 step, ironically. So the day 3 dish move was something we only did for these patients. So it was really important that we had that flagged up and clearly documented for the lab team to know that was an additional job to do. Moving the embryos was a time consideration. If someone has lots of embryos, it can take a while to make sure you're washing the embryos and moving them across properly. And I've said here, there's always a risk of embryo loss. Thankfully, touch wood, that isn't something that we have experience of, but anytime you manipulate an embryo, there of course is an increased risk in comparison to leaving it in the incubator. So that is something you have to be aware of as a possibility. And as I said, it's really important that it's clearly communicated with the patient what you're doing and when, and documented. So Stacy and Steve have showed us some fantastic clinical trials and some good data. I want to share with you a case study, and this was something that as a scientist I like high numbers, but obviously we're also emotional people and sometimes experience does give you a sense of how you're going to find something. So our first Embryogen patient was this lady who'd been through the ringer for I think 4 years, from IVFs to IUIs, FETs, and has had nothing more than a biochemical pregnancy. We did our first Embryogen transfer with her, and she had a twin live birth. So as you can imagine, that set us all off on a good path, liking this media. But obviously that's just one patient, and this is the data that we saw overall over a 3-year period. We used it over 400 cycles, and we had a clinical pregnancy rate of 34%, 56% negative outcome. What we were pleased to see was the 9% biochemical pregnancy rate. Obviously, you don't want anyone to suffer from a biochemical pregnancy loss, but in a group of patients who have all suffered repeated implantation failures and biochemical losses, that was actually a really low percentage, and we were pleased to see that. So overall, we were pleased with how the culture media was performing. And that's something I think is really important to remember. We liked it as a culture media, regardless of the additional GM-CSF. It was a good culture media that we felt was perfectly appropriate for patient culture regardless. This is comparing our Embryogen patients to our standard culture, which, as I said, was in stage 1 step. So the first line, obviously, the stage 1 step is the vast majority of our patients. Over that time period, we cultured nearly 3,000 patients in our stage 1 step. In comparison, it was only 400 in Embryogen. Still, a fair percentage of our cycles were done in Embryogen. You'll notice the mean age is a little bit higher with our Embryogen patients. That's not unexpected, because these people had often had 1 or 2 treatment cycles taking them through that period of their lives. We did replace more embryos in our Embryogen treatment cycles, up to 1.7 in comparison to 1.25 in our stage 1 step patients. The implantation rate, that is a little bit lower. We've got 23% here in our Embryogen patients in comparison to 33 in our standard culture group. Not unexpected. I don't feel Embryogen was necessarily going to improve that in a poor prognosis group, but we felt it did pretty well. The clinical pregnancy rate, because that biochemical loss rate was a bit lower, those two go on well there. However, the thing I really think stands out from this graph, and the one thing that probably stands out as statistically significant, is our multiple pregnancy rate, which was unfortunately sky high in the Embryogen group. And that's something we later really worked on, was trying to reduce the multiple pregnancy rate. My gut feeling was that if Embryogen was the thing that was fixing the issue, and if you did then put back 2 embryos, because often these patients were in the category where you were replacing 2 embryos, if you did put back 2 embryos and fix the problem that had been causing issues, then there's a good chance both those embryos may end up implanting and giving you a twin pregnancy. We did counsel patients that sometimes they should consider Embryogen with 1 embryo and then only move on to 2 if that hadn't worked. But as you can imagine, by the 3rd transfer, often patients were, in those days particularly, asking for 2 embryos. So it was an ongoing discussion, I would say. And that leads us neatly to what would be the downsides of using Embryogen as a routine or additional culture treatment for your patients. I talked about the administration challenges. That probably was the biggest, just making sure patients are adequately counselled, make sure their wishes are documented, making sure they're tracked. I think there is a risk of overuse with any additional treatment. If it starts working for the patients in which it's aimed at, you'll start having patients saying, oh, my friend had it. Oh, I've heard this online. Oh, I would like to have this. Yeah, I want to tick that box. I'm paying for it, so it must be a good thing. And there is going to be patients who would ask for it that perhaps it wouldn't be beneficial for. I don't think that's a big issue. I didn't feel like it was actually going to detriment patients to have that. So it wasn't something I was particularly concerned about. But that's something that I think you always have to bear in mind with any additional treatment. I've talked about the risk of multiple pregnancies, and I think that really was a very, very real risk in this patient group. Something we felt very passionately about in Woking was keeping multiple pregnancies down. So it was a big challenge for us to talk about doing a single embryo transfer, even in these subsequent cycles. There is, of course, a cost to the patient. It's not as expensive as some additional treatments might be, but it does carry an additional cost, and that is something that some patients will struggle with. Something you always have to bear in mind when you make a recommendation is that people don't feel that this is something they have to do. So finally, just to reflect on how I feel about it, having used it now for 10 years, I think GM-CSF is a really useful additional treatment in the arsenal of the lab. I think it's something that really doesn't carry a lot of risk in comparison to some potential things you might do. Less challenging to the patient, less costly, less risk to the embryos than some other things that may be more controversial things to try, particularly in the case of implantation failure. There can be some challenging organisation in the lab. It takes a team that communicates well and works well together, which we were lucky to have, but it might be more difficult in perhaps a different environment. I think the single-step GM-CSF is a really welcome addition. Will take away a lot of the hurdles that we found and definitely the time constraints. So that's something I'm quite excited about. I'm really pleased that Cooper have brought that out. And potentially it's something you might use as a transfer medium even without culturing. This is something to talk about, whether for the frozen culture and transfer or simply for transfer alone. That's something to consider as a possibility. I think sometimes it's important the patient has an opportunity just to try something different. They talk about the definition of madness as being trying something that's failed, trying it again. But unfortunately with IVF, sometimes you do have to just roll the dice again, and sometimes it is a numbers game. And if you can find a treatment that allows the patient to feel ready to give another cycle a go, I think that sometimes psychologically can be an important factor. So I think that's part of when I speak to patients is to say, so this might not be the thing for you, but it also isn't going to hurt, and it might just be the thing to give it another go. So I hope that's been helpful. Bit of a whistle-stop tour of Embryo-Gen in the lab. And I look forward to hopefully having some nice, interesting, juicy questions to talk about. Thanks, everyone.
Thank you so much, Catherine, and thanks also to Steve and Stacey, and I'll invite everybody back. We've got some questions that have come into the Q&A box. We've got a few in there, but please keep them coming because we can squeeze some more in. But we'll set off. We've got quite a few here. Let's have a look. Steve, we'll start off with one probably for you. Where does the GM-CSF used in the media come from?
It originally came from a company called Genzyme. I'm not sure whether it's still coming from there, but essentially it's using recombinant DNA technology, and you typically can use either a yeast system or an E. coli system or a mammalian system, like for example Chinese hamster ovary cells. But this actually comes from the yeast system, so. Yeah, it's a very, obviously being recombinant, it's very pure, and I think pretty reliable in terms of how it's produced.
Good. Thank you very much for that. Next question. Oh, we've got one here. How can I use this media in my lab if we, stage 1 step GM-CSF, that being, if we routinely use a different culture media? Stacey, perhaps that might be one for you.
So it's a single step medium. So if you use a single step medium, you'd use it in the same way. If you already use stage 1 step, your culture system is optimized for stage 1 step. So that's easy. If you use a different kind of media, that's okay. What I would say is potentially run it past myself or your account manager, or just check your CO2 concentration is going to optimize the pH in the stage 1 step GM-CSF, and we can support with that. That's straightforward. But it's a single step medium.
Great, good. And we've got a question here, and this does crop up from time to time. Is media containing GM-CSF safe to use? Steve, perhaps that could be one that you could start with.
Sorry, what was that again? Is it what to use?
Is media containing GM-CSF safe to use?
Oh, safe to use. Well, one would hope so. Bearing in mind that this is a cytokine that's endogenously secreted into the female reproductive tract, and being a recombinant product, it's just GM-CSF that's being added to the media. There have been animal studies and human studies, both of which have shown that there's no impact on the chromosomal normality of the cells of the embryo. So that's reassuring that there's no change in the genetic makeup of the embryos. And of course, there's now a number of studies looking at clinical outcomes beyond live birth. So, looking at the things I mentioned earlier. So the birth weights that, have often been looked at with different culture media, being concerned that there may be some impact on birth weight, for example. But the studies to date show no significant difference, for example, in birth weight, and indeed in other sort of neonatal and perinatal outcomes. They're all perfectly within normal limits and consistent with the other media, the control media, where studies have been done. So we have no evidence to be concerned so far. But like everything in IVF, even with things like ICSI that we think has been around forever, it's still relatively early days in terms of late onset cancers and things like that. We just don't know. We'll have to wait until that data comes in.
Okay, thanks, Steve. Question here about repeated poor embryo development. So GM-CSF, can it or should it be used for patients with repeated poor embryo development? Catherine, is that something that you ever tried in the lab?
It doesn't fit the criteria that we tended to recommend, because we were aiming for people where we thought the implantation was the issue. So generally they'd had good blastocyst development in the past. So it's not something I can speak to, but having seen Steve's the second to last study he showed, talking about rescuing people with previous arrested embryo development, it's something I would be really interested in looking at on a clinical basis. But no, it's nothing we actually did routinely, I'm afraid.
Yeah, thank you. Stacy, Steve, perhaps you've got some comments on that question.
Ladies first.
I would just echo the studies really that Steve's already beautifully described. You know, we do have you know, studies that show that it could support embryo development, whether that's due to, as Steve's mentioned, preventing the stress, it being a survival factor. You know, extended culture is stressful. We do not know, but there are studies to support that approach. I'll hand over to Steve.
Yeah, I just wonder whether there may be an overlap with Catherine's criteria, because they do include patients of advanced age, and you know, it's not unusual for the eggs from patients of advanced age to not have the same level of integrity, if you like, as the eggs of younger patients, and that can lead on to in some cases to problems with embryo development. So again, I would agree with Catherine, and I think it's a potentially interesting area to explore a bit further. And I know Diana Payne, who many people in IVF will know of, she did a really interesting study a number of years ago now, I think in collaboration with a Japanese group. And they were looking at, I mean, horrendously poor prognosis patients in terms of their embryo development. And what their solution was to wait until the inseminated oocyte had extruded the second polar body, and then transfer that zygote to the patient, rather than exposing that zygote to the stress of in vitro culture, and got some amazing results in comparison to the historical poor results that these patients had. So I think this is an area that we need to just really think about more. You know, how can we better protect these oocytes and these embryos that maybe just don't do so well in embryo culture? And, you know, a bit like Catherine's first case study, you know, I think we've all had anecdotal experiences that, you know, we get repeated failures with blastocyst transfers, switch to a day 2 or day 3 embryo transfer, and, you know, you get repeated successes with the same patients. So, you know, I just think it's something that we need to look at further.
Yeah, and something that's certainly worth consideration if you've got one of those situations. Got a couple of questions here about PGTA, so I'm going to ask them together. First one being, what are your thoughts on using GM-CSF for patients that have undergone PGT? And then following on from that, Catherine, whether you had any experience at the time of combining EmbryoGen, BlastGen with PGTA, and if so, did you see any difference in euploidy rates? So what do the panel think about using GM-CSF with PGTA patients to start? Stacy, perhaps we go to you first.
Yeah, I think this is really interesting. So obviously PGT, it's kind of, as Steve was alluding to towards the end of his talk, you know, it's more micro manipulation. You're doing a biopsy, that's stressful. Extended culture, biopsy, freezing, thawing, the embryo has to go through a lot. So if there's any way that GM-CSF can support that embryo in the thawing and transfer process, that would be a great thing. You know, in terms of its being a survival factor, you know, in terms of it supporting the immune response, you know, and these PGT embryos, they are really precious. It sometimes takes us a very long time to find a euploid embryo. We want to make sure we're doing everything we can to give that embryo the best chance that we possibly can. So I think this is a really interesting area that I would love to see to see data on, to see if GM-CSF can do what we need it to do and support these really precious euploid embryos. What's really nice about the Okabe study, the FET study that Steve shared in his presentation, is that assisted hatching was included in their study. So we know that in some of the transfers, they were assisted hatched, and then cultured and transferred in the GM-CSF. So I think that's really nice for a nice basis for anyone considering transferring a biopsied embryo in GM-CSF.
Good. Any thoughts from you, Catherine? Is it something that you ever looked at? And
Yeah.
we have got people asking about euploid rates for embryos grown in GM-CSF.
I'd love to be able to answer that, but we didn't have that much crossover between the time. We only introduced PGT into Woking in 2000, COVID lockdown time. So it's not something I have a huge experience of crossover with the two. Really interesting though. And I think transferring euploid embryos, it pushes it even more towards, okay, well, we know we've got a good embryo. Let's see what else we can do to maximize what we're going to do with it. Let's make the endometrial environment as good as we can. So there's a real case for it, but no, it's not something I can talk about euploidy rates, I'm afraid.
Steve, any thoughts from you on euploidy rates?
Yeah, I thought Stacey answered the question really well. The only other thing that always sticks in my mind, all these publications, why don't euploid embryos implant? So I think we're only getting half the story when we do PGTA, and maybe there may be situations where we haven't looked after the embryo in other ways, and that's why I just think it's a particularly interesting way to investigate the potential benefits of GM-CSF in terms of embryo survival, because, as Catherine said, all those pieces of the jigsaw need to fit together, and one of those pieces of the jigsaw can simply be surviving in vitro culture. You may have a euploid embryo, but if it's suffered too much during in vitro culture, maybe it's not going to lead to an ongoing pregnancy. So I just think it's a really, you could get the benefits of both in some ways, which would be nice.
Yeah, that would be great, wouldn't it? Again, got a couple of related questions here. So someone asking, can I use stage 1-step GM-CSF for all patients? And a similar question to Catherine, do you now use the GM-CSF media routinely as part of the culture system for appropriate patients, or is it still an additional charge item? So firstly, perhaps we take Stacy, your thoughts on using GM-CSF for everyone?
So there's no reason why you can't, but we have to bear in mind that the evidence base so far suggests that the benefit is greatest in the subsets of patients that we discussed in the webinar. So that's recurrent implantation failure, miscarriage, advanced maternal age, and then of course we now have the study looking at using GM-CSF for FET cycles, and that is showing an improvement in live birth rates in that particular study. In terms of using it for everybody, if you look at big studies like the ZEEB 2013 study, they saw an overall trend for higher pregnancy rates in the GM-CSF group versus their control group. But that was a trend, that the benefit was significant and more pronounced in that subgroup for patients that had undergone previous miscarriage. Obviously, whether or not that would change, now we've got a single step media, I don't know, but that's what we know so far.
Great, thanks for that, Stacey. And Catherine, we'll address this question around charging because it's something that clinics often want to discuss. So are you offering GM-CSF routinely, or do you plan to? And how will you charge? Do you know?
Yeah, I mean, probably I'd love to, but in reality, unfortunately, it's not something that I think can be justified to charge every patient the additional amount you'd have to buy it in for everybody. The bottles that come are designed really for a small number of patients, and that's how the whole thing's priced. So I think probably in reality, it's not something I'd find easy to justify charging for someone their first cycle at a young age. If you could absorb it into the cost of the cycle, absolutely. I don't think I'd have any problems with that. I just think it's on the practical level.
Yeah, no, understood. We've got questions coming in thick and fast now. We'll keep going as long as people can bear with us. This is great. So I got a couple of questions about hyaluronin. So somebody asking, is the hyaluronin in the media? And a follow-on question from that, somebody asking, is GM-CSF the agent that's giving the benefit to embryo development and implantation, or is it the hyaluronin? So Steve, perhaps you could take those questions on hyaluronin.
Yeah, very interesting question, very valid question, because you know, if you're thinking of this as a transfer medium, it could well be the hyaluronan that's having the benefit rather than the GM-CSF. I tend to think of it a bit differently because, well, for two reasons. One that you know, you've also got the culture period leading up to the embryo transfer, so there's that to take into account. Now, hyaluronan isn't a survival factor. I mean, there is some evidence that it helps embryos survive cryopreservation to some extent, so it can sort of, you know, buffer the stress, I suppose, to some extent, but it's definitely not a survival factor. And when it comes to embryo transfer, I think that if you look deeper into how these different compounds are likely to be exerting their effects at around the time of implantation, you've got one that's, you know, maybe mediating the immunological response of the uterus, and the other one is it's not really adhering embryos to the lining of the uterus. If anything, it's produced within the stroma, and it increases the sort of spaces between stromal cells. So you can imagine that you know, that it's helping later stages of implantation. So maybe you know, when invasion is occurring, opening up the space for the trophoblasts to invade the endometrial stroma. So I sort of think of them as performing different roles. Of course, you know, unless you take out one or the other and do those studies, you can't know for sure to what extent they're contributing. But I mean, they both have a role to play. So I think in the, you know, in the best world, you'd have both. You'd have both, and whatever else you can throw at the endometrium to try and encourage the embryos to implant and maintain their implantation.
Great, thank you. And following up on from that, actually, there is another question around media. Will we see any improvement using this media over our current transfer media, which is not being specified, but I guess could be a culture media or another transfer media on the market? So what kind of evidence do we have for using this media for frozen embryo transfers? Steve, Stacy, perhaps one of you two would like to jump in on that one.
So you had it was kind of two questions there, wasn't there, Emily? So the first part of the question was, will I see a benefit compared to my current media? And the second question was frozen embryo transfers. Okay, so will I see a benefit? So if we just think about it as I guess a fresh culture media for the first part, it depends on how you use it. You know, we've talked about the subsets of patients that the evidence base currently shows that GM-CSF can help. And then second of all, I think Catherine explained this really beautifully in her talk. When we are looking at our KPIs, when we're reviewing our pregnancy rates, it's really important that we compare apples with apples, because our GM-CSF group is likely to be patients that are struggling with their fertility treatment journey. You know, they may have had repeated implantation failure, miscarriages. You know, it wouldn't really make sense to just, well, you know, if you compare them with your standard culture media patients, just very, you know, this and that, you know, you may not see a difference, because obviously your patient groups are different. So we need to bear that in mind when we're reviewing our data. Or we could potentially use historical controls, retrospective data, go back and compare the same subgroup to see if the GM-CSF is in fact, you know, having an effect and showing a benefit. The second question about frozen embryo transfers. So, you know, as far as I'm aware, the study we have at the moment on frozen embryo transfers was the study that Steve explained beautifully earlier on in the webinar. It was the OCARBI study. That was a really lovely study that just essentially showed thawing in the GM-CSF 3 to 5 hours, and then transferring in the GM-CSF. And that showed more than a 10% increase in the live birth rate in comparison to the standard culture media. So it goes back to everything Steve's already explained. It's a survival factor. Freezing is stressful, extended culture is stressful. It would make sense really that we would hope GM-CSF may play a role in supporting those embryos.
Super.
Anything to add, Steve?
Nothing to add. I think you've summed it up beautifully, Stacey. I think the tendency is to confuse the two, to confuse survival during culture, whether that be standard culture over 5 days or recovery culture following vitrification and warming. They're both culture, and actual embryo transfer. And for me, the evidence is far more convincing of a benefit during those culture periods, whether they be overextended in vitro culture or in recovery culture. I'm less easily convinced by the potential benefits at embryo transfer, but who knows? I mean, I think Sarah Robertson explains it, that there's this glycocalyx that lines the epithelium of the endometrium, and that could sequester agents like GM-CSF and have a local beneficial effect. I just think you just need to keep it clear in your mind what you're trying to address and what's the best way of going about that. And of course, we know that many patients will succeed without specialized culture media or specialized transfer media, or without assisted hatching and all these other things that you could be tempted to use across the board. And you just have to identify those patients that are likely to benefit versus those that really don't need them.
Great, thank you so much. Question for Catherine: have you got any tips on how to talk to patients about culturing in media with GM-CSF?
Yeah, it's one of my favourite parts of the job, to be honest, is talking to patients about what might benefit them. I mean, honesty is always the best thing. Talk to them about the pros and cons. Don't try and, I'm not a salesperson, that's not my role. Talk to them about why you think it might help them. Give them the evidence you've got, but make it as tailored evidence as you can do. If someone's having a fresh cycle, talking to them about frozen cycles probably wouldn't be, it's just going to muddy the waters. Try and tailor make your information to the patient's level of need for information. Some people, if I was coming through IVF, I'd be wanting the papers, other people just want to be told, should I have it? Yes or no? Yeah, I'll go with your advice, a lot of people say to me. So I try and make sure that even those who say, well, what should I do? I make sure they actually understand why I'm recommending what I'm recommending. But otherwise, it's just a case of, make sure they have information in a form that's accessible to them. Some people prefer verbal information, some people prefer written. Most people like a graph. Visual information is really important, and it means they can take it away and look at it later as well. So I would generally recommend that people can do it in their own time, and then give them time to come back and ask questions later. I think it's really key that you don't leave someone saying, well, that's it, we've made the decision. They can go away and either opt in or opt out, as long as they know when that deadline would be to have the treatment type confirmed. So yeah.
Lovely, thank you so much. And a kind of follow-up question for you then. Could Stage 1 GM-CSF be used for unexplained fertility? Is that something that you would ever recommend?
Yeah, I mean, it could be used for anybody. I think that's a simple answer to that, really. There's no category that would say this is a contraindication for using it. And one of the things we keep coming back to is everyone who has a recurrent implantation failure had a first transfer. We don't know who these patients are until they get to their 4th or 5th transfer, but they all did have a first cycle. And the only complaints I've ever had in my years of embryology about this have been someone saying, well, why didn't you recommend it for me before? So yes, you could. I think our job is probably not to offer a buffet of options on the first cycle, because as Dr. Fleming was saying, a lot of times patients will succeed without any additional treatments, and IVF is a complicated and expensive thing enough. So I don't know if I would recommend it on someone's first attempt with unexplained infertility, but you certainly could. Yeah, I don't think there's anything wrong with it.
Good, thank you for that answer. And someone inquiring, Catherine, in groups of patients older than 35 years, how often do you transfer more than one embryo, and in what cases? And I guess that might have also changed over this period of time, because we are going back quite a bit in time, aren't we, with your data?
Exactly right. Yeah, that's exactly right, Emily. So the data I shared was from back in 2016. I mean, practice across the UK, the world has changed since then. These days, we very, very rarely transfer 2 embryos in any circumstances. In 2016, in our 3rd attempt, we did a bit more. We were passionate about reducing multiple implantations. So even then, we did less than most UK clinics. But yes, we did do more. I think we were at 1.7 for our embryo gen cycles, who were on their 3rd transfer at least. So we still weren't doing 2 in a lot of them, but that number would be a lot lower now.
Yeah, thanks for that. Thank you for answering that one. And then I got a few practical questions. Stacey, I'll go to these on you, quite rapid fire practical questions, I think. What concentration of CO2 would you recommend for this media?
Oh, okay. So stage 1 step in the UK tends to work well at around 6%. We know that. Obviously, we always recommend testing the pH to know what it actually is. But very roughly, it tends to work well at 6% in the UK.
Super. And how could somebody test the pH if they wanted to get that reassurance?
So we can offer pH testing. You can do it yourself. The best way of doing it is a blood gas analyzer. Yeah, that's the most accurate way of doing it.
Lovely, thank you. How many patients from 1 bottle of stage 1 step GM-CSF media can be treated?
These all for me.
They are. I am.
Okay. So
I thought that would be for Catherine.
Rapid fire
it depends on your protocols. There's 3 mils per bottle. So it depends on your protocols, doesn't it? Average, I'd say probably around 2 if we're talking 2 FETs. I don't know, two fresh cycles, but it really depends on your culture, your protocols.
And also the length of time you'll keep the bottle open. If you're only having one patient coming through a week, you would use that bottle just for that patient. Okay.
Great point. Yeah.
Good. And then one last practical question for you, Stacey. What is the longest period of pre-equilibration of the 1-step stage media before the embryo incubation? It means, what's the maximum period that I could prepare my medium before use?
The maximum period?
Yeah.
So we tend to say prepare media the day before. That's going to give you the full equilibration window that you need to make sure that it's the right pH when you place your embryos in. So the day before is what we would suggest.
Super, thank you. Well, made it through all those questions. So thank you so much to the panel, and thank you actually to everyone who submitted questions there. That was a great response. So yes, we've come to the end of our webinar. Thank you so much for joining us. A massive thank you to Stacey, Steve and Catherine. I think we've all benefited hugely from your expertise today. Particularly, that was a very interesting questions and answer session. It was also really great to hear Catherine's story as well, and the use of GM-CSF in just real life in practice at Woking. So thank you so much for sharing that. And also thank you to our marketing manager, Tenna. You can't see her, but she's in the background running the webinar for us today. And thank you to Tenna. If you would like to be kept up to date with our webinars and in-person events, of which we run many, then you can do so by signing up to our fortnightly news bulletin. To be registered to receive this, just send us an email at marketinguk@CooperSurgical.com. That's marketinguk@CooperSurgical.com, or ask your account manager. So it just remains to me to thank our audience for joining us today. And if you're interested in stage 1 step, it is available now with GM-CSF. So do talk to your account manager, or you can order this from our customer services team at customerserviceuk@CooperSurgical.com. So thank you very much, everyone. Thanks again to our panel. Thanks to our delegates who've joined us today, and have a great rest of your day. Thank you. Bye.